Assistant Professor at Dr. K.K.B.M Hospital, moderator for the free paper session. We have gathered here for this free paper session where residents from various medical colleges across Uttarakhand and UP would be presenting their original work. Today we are having 10 free presentations. Delegates kindly note that each session is time bound, lasting 5 minutes, at the end of which a buzzer would be struck, followed by a 2 minutes discussion. Kindly stick to the timeline. Now, I would like to introduce the convener for this session, Professor Dr. Yusuf Rijvi, Head of the Department of Ophthalmology at Dr. K.K.B.M Hospital, Dehradun.
On behalf of the entire faculty members and colleagues of Gautam Buddha Chikitsa Mahavidyalaya or GBCM, I welcome all the delegates for this free paper session. So please. So we welcome Dr. Harsh Bahadur, who has just joined us. He is one of the judges of the session. In Subharti, there is a tradition to start the proceedings with a big Jai Hind. So there is a Jai Hind to all the delegates who have come, and I hope that your participation is going to be both enriching scientifically as well as enthralling to all the delegates who are present. So without much ado, I will start with the first speaker of the day, Dr. Tanvi. Dr. Tanvi is from SGR. Is she there?
She is not.
Okay, Dr. Tanvi has not reported, so I'll now request Dr. Priyanka Saran.
Yes.
Okay. So Dr. Priyanka Saran comes from Subharti Medical College, Meerut, and she will be presenting a case report, an unusual presentation of corneal ulcer in case of erythrodermic plaque psoriasis. So over to you, Dr. Priyanka.
Good morning, everyone. Today I will be presenting a case report on an unusual presentation on corneal ulcer in case of erythrodermic plaque psoriasis. Introduction: psoriasis is a chronic immune-mediated skin disease that can also affect the eyes. The most common variant of psoriasis is plaque psoriasis, which accounts for 80% of all cases. And other common types are nail psoriasis, guttate, inverse, pustular, and erythrodermic psoriasis. Ocular manifestation in psoriasis eyes can be involved due to overactivity of immune system that triggers inflammatory responses. Commonly encountered presentation can be keratoconjunctivitis sicca and blepharoconjunctivitis being the commonest. Other can be conjunctivitis, episcleritis, keratitis, and uveitis that often follows an exacerbation of cutaneous lesion. Ocular manifestations are more common in patients with erythropathic or pustular psoriasis. Recurrent episode of ocular manifestation can lead to chronic scarring, vision impairment, and blinding if left untreated. Now the case report. A 35-year-old female patient was admitted in dermatology ward in Subharti Hospital, Meerut. She was diagnosed with exacerbated plaque psoriasis. She was also referred to ophthalmology team on the day of her admission due to her complaint of diminution of vision, discharge, discomfort, and redness in both the eyes. On examination, her head posture, facial symmetry, and chin position were normal. On forehead, there were crusty plaque lesions. This was the presentation of patient. On ocular examination, visual acuity in right eye was PL positive, PR accurate. In left eye, it was 1 to 2 meters. On eyebrows, there was crusting were present in both the eyes. Periorbital muscles were intact on palpation, and on eyelid also there was plaque psoriasis with matting of eyelashes in both the eyes. Conjunctiva, deep congestion was present. Mucopurulent discharge was present in both the eyes, and this was the corneal presentation. In right eye, stromal ring infiltrates present in mid periphery with 3 mm paralimbal clear corneal zone. Central corneal thinning was also noted. Sensation was reduced in both the eyes. In left eye, it was geographic ulcer which was extending from 11 o'clock to 6 o'clock, and hypopyon was present in right eye. Provisional diagnosis in right eye, herpes simplex virus stromal ulcer with secondary bacterial infestation was diagnosed. In left eye, it was geographic ulcer. On day 1 management, corneal scraping was sent for QH mount, gram stain, blood, and chocolate agar. On treatment, we gave tablet doxycycline LB 100 mg 2 times a day for 7 days, Pentop, vitamin C for 3 times a day. In both eyes, fortified vancomycin and ceftazidime was started for 1 hourly and moxifloxacin for 2 hourly, and lubricating was starting for 1 hourly, and atropine was started for 3 times a day. In right eye, brimonidine and timolol was started for 2 times a day, and in right eye, fluoromethanol was started for 4 times. For night, lacryzel was given for night, and acyclovir in left eye was advised. On day 3 of examination, in right eye, digitally the eye got soft, and in cornea, along with ring infrared, microperforation in center was noted, and even CDUS positive was present. In left eye, the vision got improved from 2 meters as ulcer was reduced. On day 3 management, QH mount, no fungal element was seen. Gram stain was positive for the cocci, and on treatment, microperforation was sealed with cyanoacrylate glue. Then BCL was applied under aseptic condition. Tablet valcyclovir 1 gram 3 times a day was advised for 5 days, and in both eye, moxifloxacin was reduced from 6 to 2 hourly to 4 hourly, and fluoromethanol was increased to 6 times, and acyclovir ointment was started in right eye for 3 times a day. Rest treatment was according to day 1. On day 10, on forehead, the scaling and crusting lesions were in healing stage, and in right eye, visual acuity improved to hand movement close to face, and in left eye, it was 5 finger counting at 5 meters. Even on eyebrows, the scarring and crusting was in healing stage. In cornea, with ring infrared, there was a sealed microperforation in center with BCL in situ, and anterior segment was shallow and quiet. On daytime management, tablet doxycycline LB was given for OD for 4 days, and valcyclovir was also was shifted from 3 times to 1 time a day for 5 days, and freshly fortified drugs were made after 1 week. Discussion and conclusion. Given the patient's underlying psoriasis, the ocular findings were considered to be related to a systemic condition. The patient was managed by both dermatology and ophthalmology teams with initiation of topical ocular treatment for a blepharitis, conjunctivitis, alongside adjustment of her systemic treatment for psoriasis. Additionally, the patient was advised to undergo right eye penetrating keratoplasty once her condition stabilized to address the potential long-term corneal damage. This case highlights the importance of interdisciplinary care in managing patients with psoriasis and ocular manifestation, and need for prompt evaluation and treatment to prevent long-term visual complication. Thank you.
The session is open for questions. Are there any questions?
Well presented. So it
Okay.
was truly a very rare case, having an overlap of a rare variant of psoriasis, and I believe it was proven by the dermatology wing that it was rheumatism, because it's a rather rare type of psoriasis in India. Was it labeled?
Yes, ma'am. From dermatology team, it was they diagnosed as an eczema damage because the patient was on follow from last 6 years, and she presented with the ocular complaints at the time of admission in Subharti.
And when looking at the systemic condition of the patient and the scaling and the damage to the dermatological, it seems that she was probably not very compliant with her visits and treatment.
Actually, my patient was very cooperative. She was like, if you want to see me on for repetitive days, she was very she was not so much able to move from here and there, but she was
She was a good clinical case.
Yes, yes.
So are we aware of the immunocompetency level of the patient and what systemic treatment she was on?
Systemic, ma'am, it was from the dermatology team. She was on other medications from dermat team.
Psoriasis, the treatment which is given by dermatologists, which is usually exiguous as well as retinoids, both have relevance in ophthalmology.
She was on clindamycin, the ointment, and that.
It's mainly an immune disease, so immunosuppressants, immunocompetence level of the patient is something we have to learn from. This was a case which had viral conjunctivitis better line of management on that will was good, because it is definitely going to affect the ocular healing process.
Yes, ma'am. Because our main component was the systemic, due to which the ocular manifestation had occurred.
That's right.
Thank
Just
you,
one
ma'am.
curiosity. What was the rationale of using what was the rationale of using antivirals, that too in high dosage in this case?
Because sir, on when we have started the broadly, we have given the broadly treatment, and on that she responded to antiviral. That's why
It
we
was
just
an empirical basis on which you started
yes sir,
viral
yes sir. Then
antibiotics.
eventually the patient was improving. We saw the improvement. Then we just continued with that, and the patient got much better then.
Because most of the viral conditions, they are superficial, they don't go into operations. So it was more or less an empirical line of treatment you could have done even without the antivirals. What do you think about it?
Yes sir, we can think about it, but the patient was responding,
Okay.
then we went for
Okay.
that. Thank you.
you.